It's a pleasure and an honor to be with you today. I know that you're in Knoxville, Tennessee at the Cole Center, and I'm extremely grateful to Dr. Tolson and colleagues who have visited the University of Florida for inviting me to give one of your talks this year. And what they have asked me to share with you is just a little bit about the emerging therapies in Parkinson's disease and how we got there. And my name is Michael Okun, and I am a neurologist, and I work at the University of Florida. And here I'm going to share my screen up with everyone so that you can see. And my Twitter handle is at Michael Okun. I am a medical advisor for the Parkinson Foundation, and I work at the Fixell Institute for Neurological Diseases. And we run a blog with Indu Subramanian at UCLA and Johnny Atchison, who's a great artist from the UK who has Parkinson. And we run a blog called Parkinson Secrets. And so we're happy to answer your questions. And I also want to point out that the Parkinson's Foundation, we had this really awesome helpline, 1-800-4PD-INFO, if you ever need to get info about Parkinson's disease. And these are just the top nurses in the field. And so, again, thank you to the Cole Center. Super, just amazed to be part of your great event. I'm really happy that this is still going on virtually and everybody's going to be able to get a chance to get all the education. These are my disclosures. I do receive multiple grants, as you can see here, from the National Institutes of Health. Those are public grants, and so I want to make sure I disclose that. I also work for the Parkinson's Foundation, as I mentioned, and we have a Center of Excellence at the University of Florida, and then also several other foundations, some book royalties, associate editor for a few things, and I do teaching courses, but I don't take any money directly myself into my pocket from any industry sources. We do have partnerships for clinical trials and devices with different pharma companies and device companies, but I'm non-conflicted and I just want to make sure you understand my disclosure so you can ask me any question. This is our group at the University of Florida. Super proud of them. This is the Norman Fixell Institute for Neurological Diseases. So if you're heading down I-75 and you stop in Gainesville, Florida, which is where the University of Florida Go Gators is at, feel free to stop by and say hello. We're all under one roof: rehab, in-store, outdoor waiting, research wing, clinical wing. We're building a new imaging wing as part of this. And so you can get all of your care in one place and one stop, and also access to research, which is what we're going to talk some about today. And I just want to mention a couple of books that you may have seen in the news. And this Ending Parkinson's Disease book is the most recent one, and all the proceeds go to charity. And we also had a recent red card campaign to the White House where we sent in 30,000 red cards to try to increase advocacy for Parkinson's. So super important. And then, of course, we continue to write books about tips and secrets. And the latest book we have with Irene Malati and Wissam Deeb is on living with Parkinson's disease.
We have done the impossible before. The suffering we experienced, it pushed us forward. It did not stop us. Stigma was there. Our brothers and sisters marched on the streets until it wasn't. The challenge inspired us. Together, we rose to the occasion. We fought back. And we will do it again. We will end Parkinson's. Our fight begins now.
So if you want to join our red card campaign to the White House, you can go to endingparkinson.org or to parkinsonsecrets.org and sign on to our petition. And I just want to point out a couple of things. One, the problem is actually quite large. And, when we think about the problem, we've got to think about how fast things are growing. And now we know through the World Health Organization and verified by other authorities that Parkinson is now the fastest growing neurological disease. And so that should catch our attention. We know that 1 in 15 people will get Parkinson within a lifetime, which is a lot. And if we look at the numbers, as the numbers go up, and you can see from 1990 to 2040, you can see this more than doubling in the 15 years, actually the 25 years from 1990 to 2015, and then the next 25-year epoch, another more than doubling. This is going to have serious ramifications. It's going to have serious consequences on our healthcare systems around the world. And it's something that we need to pay attention to. And not the least of which is the most important things. People are going to suffer with the symptoms. And so we want to make sure that we can help folks. So what are the next steps? And when we wrote the book, and again, all the proceeds go to charity on the Ending Parkinson's Disease book. So just so you know, we looked for what are the pillars and what in other diseases where we've seen successes, what have we seen people been able to do to get ahead of diseases. And the idea is that Ray Dorsey, Boss Bloom, and Todd Scherer and I came up with this idea after studying different states like HIV and polio, that what we need is a pact. So we need to be able to prevent, advocate, care, and develop new treatments and research, which we're going to talk about today because we're supposed to talk about emerging therapies, which I'm excited about. Now, when we talked about that red card campaign, if we think about preventing, if we're going to prevent Parkinson, we've got to ban specific pesticides and specific chemicals. And you may see that chlorpyrifos was just banned here in the US, which is great, but the FDA reversed and still hasn't banned paraquat. And paraquat is the pesticide with the strongest link to Parkinson. It's been banned in 32 countries. And in the US, its use has doubled in the last 10 years. Now, if we look here just at the gray bars, you can see what's happened from 2014 to 2016 and this huge increase. And it's all over the country, but you can see it here in the farming belt, the South, the East. It's all over. And then you can see across the agricultural regions of California. Now, you have to ask yourself when you're thinking about these things, where do you live? And my house is 11.3 miles from a Superfund site that has dioxin, which is an element found in Agent Orange, which you may know from Vietnam is named so because of the orange barrels. It's an herbicide that was sprayed out and is now clearly related with a later onset of Parkinson's disease. It doesn't mean you can tell with every single case, but it means when we look at those populations, when we do odds, and that's what we do in statistics, the odds are that people that were exposed to this in Vietnam have a higher risk of getting Parkinson's disease later. And that's why folks get benefits for this. And so when we're talking about emerging therapies, I don't want you to forget about the idea of what we need to do now to prevent things. So we need to think about banning certain pesticides and certain chemicals. Those are things that we can do. So you could think of that as emerging. Another one commonly used in dry cleaning is trichloroethylene, or TCE. It comes in a blue barrel, and TCE has a very high odds ratio, meaning that if you take a population and you look at exposures to TCE, the chances of getting Parkinson is higher than those who are not exposed. And this is commonly used in dry cleaning. So again, you got to think about preventives too when you're thinking about stuff that's emerging. So in terms of advocating, remember we talked about prevent, let's talk a little bit about advocating. We have to ask, what did we learn from diseases like polio and HIV? And we see here FDR talking to the head of the foundation that then later formed the March of Dimes and recruited many stars like Bob Hope and Eddie Cantor in. And having an advocate in chief for a disease is hugely important. And so something to consider as we think about how do you get ahead? How do you advocate effectively? And people mailed dimes to the White House. That's actually now illegal because part of our campaign with the Red Card campaign was called Give a Dime for Parkinson's Disease, so-called from the history of this that we saw during the polio epidemic. But this effort led to so much research that we ended up with vaccines, as you know, the Salk and the Sabin. Now, when we think about other diseases, you think about HIV, they've been much more effective at advocating. And here you can see a condom put on Jesse Helms, a congressperson from South Carolina, that says a condom to stop unsafe politics Helms could be deadlier than a virus. And the reason they did this wasn't because they had a vendetta personally against Jesse Helms, is that he kept voting against legislation for HIV. And so once they did this, he actually stopped blocking HIV legislation, which helped them to grow and to get the type of support they need to make a difference. They also peacefully sat in at the FDA, as you can see here, and did quilts. And so when you're thinking about advocacy efforts, I think when we're talking now at the Cole Center today, I want you to think about how effective we've been. Let's be reasonable and say, look, I've been an advocate my whole career. I'm sure many of you have been advocates, but we need to sum our voices, amplify our voices if we're going to have a chance to get ahead of this disease. So all in all, our efforts have been somewhat disappointing as the disease continues to grow unchecked. And so I think we should re-examine, perhaps rethink the idea of advocacy. Let's talk about care. So we talked about the PACT, prevent, advocate, care. So let's talk briefly about care. And we like to give out lots of little tips. And I think tips are important because so many folks are suffering with Parkinson. I try to do a video tip with my daughter each week on our Twitter channel at Michael Okun, and just give out free little things that people can get help with. We did the 10 Secrets to a Happier Life, and then Irene and Wissam and I put together this fun little book called Living with Parkinson Disease. And so just thinking through Parkinson, remember, it's like a red thread. And this is a paper that was written by myself and Boss Bloom and Christine Klein that came out this year as a seminar in a journal called The Lancet. We have to think through, there are symptoms before Parkinson we call prodromal. There's the diagnosis. And then if you follow the red thread, we have to initiate treatment. We have to deal with response fluctuations, and then we have to deal with issues that come at the end of life, whether they have to do with Parkinson or not. And so we have to follow that red thread if we're going to deal with this in a rational way. And one of the most important things, and as I talk about emerging therapies, I'm excited about this slide because everybody that knows the Norman Fitzgerald Center at UF knows that for 20 years, I've said the patient's the sun, and it should be now the person is the sun. The person with the disease is the sun, and we should all orbit around the patient. And when we orbit around that person, okay, and it's an individual person, so we shouldn't call you patients, okay, particularly when we're with you, maybe at medical conferences and in some of our jargon and in scientific papers, but we should be treating you as persons, and we should put all of our people around you, and that includes the research mission. So this is just to remind you, Bob Dean took these beautiful photos. These are photos for every chapter in that Living with Parkinson book, that Parkinson affects real people. There are real faces to this disease, and we should definitely take that seriously. Now, in terms of diagnosis and treatment, there's been some recent reviews. This is one that Melissa Armstrong and I had in the Journal of the American Medical Association in 2020. And I'm going to draw your attention to this, not because it's a busy slide, but because I want to make one point. Parkinson is not a disease just of dopamine. Let me say that again. Parkinson is not a disease of just dopamine. And you see this busy slide. You can see we have things that affect dopamine, another chemical called serotonin, one called norepinephrine, one called acetylcholine, and there are even other chemicals. And when we choose drugs and we choose cocktails for you, and we talk about emerging therapies, remember, Parkinson is not a disease exclusively of dopamine. Now, one question that people always ask is, what are some of the other emerging things that you can do, to get a hold of Parkinson disease? And one of those, our graduate student, Kristen Sawowski, who worked with Dr. Park and then in Dr. Haas's laboratory, talked about using the metronome and using different ways to improve both your arm swing when you walk, but also your stride length when you walk. So when we think about emerging therapies, I don't want you to forget, everybody focuses on the drugs and the next great thing. Some of these things can have tremendous benefits. And so we challenged people on Twitter here recently to post your videos about moving and grooving. And it turns out that grooving is the experience of wanting to move when you hear music, and the pleasure of the music and this groove phenomenon actually helps with your Parkinson. Now, doesn't that make you want to move your arms and move your legs? And so I love the Bee Gees, but there is a groove to that, and I think it's important, that we both think about motor symptoms, non-motor symptoms, and think about things that we can do in a multidisciplinary way to try to treat this disease. And so I think this is a fun one. You can see these videos are up on parkinsonsecrets.com. We have lots of discussion that goes on our Twitter channel at Michael Okun, and happy to have you join in. But I think it's important for us not to forget about some of these other therapies. Now, research, emerging therapies. This is what Dr. Tolson asked me to talk about and to make sure that I covered. And I know from traveling all over the world, I've had a great, blessed life, but I know better than to talk to a group of folks with Parkinson or a group of families that have been touched by it or communities without talking about some of the things that are coming and on the horizon. It's super important. People are waiting, okay? I think of it as the guy standing on top of the world, looking down at his or her watch and saying, come on, let's go. We gotta go. There are people that have this disease and people are waiting. And when we think, and again, putting it in perspective, the Ending Parkinson's Disease, we came up with this pact. You want to prevent, you want to advocate, you want to care, and then you want to develop new treatment. So this is the T in the pact. And all the diseases, all the folks that have gotten ahead have followed this pact. And so that was part of the formula that we talked about. Now, HIV receives $3 billion a year in support. That's billion with a B, folks. That's billion with a B, from the National Institutes of Health. And the National Institutes of Health is the largest funder of research in the world. This prevented thousands, if not millions, from ever developing Parkinson's. In 2019, Parkinson's got about 201 million. That may have ticked up, closer to 250, a little bit more than that. But that's not even a fraction of what we need. And so when we sent those red cards to the White House from endingpd.org, when we send those red cards, we sign that pact. One of the things that we asked for was increased research by 10 times. If we don't increase, we're not going to see the emerging therapies that we need to move the needle. This is what happened in polio. This is what happened in HIV. This is what needs to happen when we think about emerging therapies for Parkinson's. So we also need to think about what's on the horizon. And what's on the horizon is we're beginning to target specific genes. And one of the little tips that we give on Parkinson's Secrets and on our Twitter handle is we talk a lot about just what can you do? And you can go to clinicaltrials.gov. Okay, that's the registration site where you can see anything registered, and you can type in the word Parkinson's disease. And of course, you're going to get, a million hits, right? Not a million, but too many to be able to cone it down. And if you look on the left, you can actually choose your age, choose your gender. You can choose whether you're looking for early trials, later trials, devices, drugs, and you can move it down into the hundreds and sometimes into less. So you can look through and you can see what's available, what's registered as a study that's close to you. And if you look through those, you're going to see some interesting things. And one of the interesting things that you'll see is we're beginning to focus on some people that have specific genes, specific DNA abnormalities that are associated with Parkinson. And so one of those is the GBA gene, another is the LRRK2 gene, and another is the Parkin gene. And even though these are a minority of defects, and so you can say between 10 and 20%, depending on which geneticist and how you count them, it's just like everything, right? Depends on how you count it, right? But certainly, the majority of Parkinson is not a specific gene. But if we understand those genes, we understand the pathways, we understand what makes them work, and then we can intervene with some of these genetic pathways. We believe a lot of Parkinson may have common pathways. And so this is super important, and there are efforts going on. We're involved in one through the Parkinson Center of Excellence, looking at how we can get everybody genotyped. Okay, so there's a study called PD generation, and so that'll be important. But don't be disappointed for emerging therapies if you end up not having one of the Parkinson genes or one that's known at this time. You're with the majority. You're well within the majority. Okay, you're with the 80%. But we're beginning to target those pathways and see what happens. We're also beginning to take the devices that we implant, and many of you who may know of us at University of Florida, we do a lot of device work. My NIH laboratory, funded laboratory, does a lot of work on neuromodulation, and we're improving those devices. They're smarter, they're faster, they're sleeker, and hopefully we're going to be able to improve the benefits that we see and lessen the side effects. There's also been advances in drugs and in choosing drugs. And so we're seeing large screenings. And so one of the interesting papers we saw come out in a journal called the Journal of the American Medical Association Neurology, or JAMA Neurology, was an article about folks who had been on these TNF alpha, tumor necrosis factor alpha drugs, which are drugs that are given to people that have a lot of inflammation. And it turns out the people that got those drugs seem to get less Parkinson. Does that mean if you take those drugs, you get less Parkinson? Well, there's a debate, and people are starting to research that. But again, this idea of using this information, using these observations to develop the emerging and next generation therapies, something I really want to emphasize with you today, because it's super, super important. And this is a great quote by Franklin Delano Roosevelt, of course, the only president to serve 4 terms. And he had a lot of cool things and a lot of cool quotes. And in fact, if you look at one of the things that Roosevelt talks about, he often talks about throwing stuff up against the wall. And if it doesn't turn out right, we have to modify it as it goes along. But I love that word, modify. So what has been this effort in Parkinson disease, this very confusing multi-decade effort, has been, could we give you a substance? Could we just have you take something, a pill or some substance, you take it by mouth, and it's going to slow down the disease, and maybe something else. If you're a man, maybe prostate cancer. If you're a woman, maybe heart disease. I'm just throwing those out as examples. Maybe those things will overtake you, but the Parkinson won't affect your life. Can we slow the Parkinson to a level that doesn't matter that you have Parkinson anymore, based on the actuarial tables of how long you're going to live? And so we've seen multiple studies now. Most recently is Radipine, is one of those large scale studies that was a blood pressure drug, inosine, a gout drug, pioglitazone, a diabetes drug. Multiple anti-malarial drugs have come out on these drug screenings. It's interesting, you saw that in COVID-19 as well. It didn't pan out in COVID, hasn't panned out yet in Parkinson. And so we think about what we call repurposing. Repurposing. We purpose it to do something else. So are there drugs that are out there that could in some meaningful way slow the disease progression or slow the appearance of symptoms so you can live with them longer? This is an emerging area, and one you need to keep your eyes on. One emerging area that is moving closer and closer to reality is what we've been doing for a few decades, and that's putting these electrodes down into folks' brains, listening to the circuits and trying to eavesdrop on them, listen to what they're saying, and trying to change their communication to improve symptoms. We're getting better at this. In fact, now we're beginning to implant. There's even one FDA-approved device. There'll be more where we can read off these in real time. And there's a clinical trial going on to see if the signals coming off of these, and this first clinical trial looks at a signal called the beta band. Can that be used to, in a smart way, when it picks up that beta band, and the beta band is associated with stiffness and slowness, and in some cases, but not all, tremor, can that be used to modulate in a smarter way? And so these smarter devices, smaller, sleeker, smarter, keep your eye on the field here. We also think about something called optogenetics, and there's a wonderful new book that's written by Carl Dieselroth, who's one of the fathers of optogenetics. He's a psychiatrist in Stanford. He was a keynote speaker for us recently at the DBS think tank. And optogenetics, optolight genetics, we just talked about DNA. It combines genetics, engineering, optics, the study of light, and placing these light-sensitive molecules in the brain. And then as you can see, as we shine this light into the animals, we can achieve very precise control of these circuits. More precise than if we just stick a straw in like we do in deep brain stimulation and just throw electricity. We can actually turn on and off, very specific in very fast millisecond timeframes. And this allows us to understand the circuitry of the brain. This hasn't driven to a human therapy, but why is it emerging? Why is it important? Because it's telling us where we need to go. Carl Dieselroth talks about this. Megan Creed at Washington University talks about this idea of optogenetically inspired deep brain stimulation. Understand and then design based on the understanding. And also, as Megan Creed and others have shown in a series of recent articles in Science and other great journals, they've shown that it's not just the stimulation, but it's also thinking about the medications and the disease state all in combination. It's a whole milieu, and we have to think about the whole picture and not just one piece of the picture. The other thing that's really interesting and emerging is an idea of beginning to look at designer receptors that are activated exclusively by designer drugs, the so-called DREADs, and this is most used in cancer, and so we're starting to see folks pull over. And again, a lot of the Nobel Prizes that are won and a lot of the great discoveries come because someone sees something in another area and pulls it in. So we really want to, as we think about emerging therapies, we really want to get people to pull therapies from other diseases and other approaches and to think out of the box. And of course, one that is really, taken off and people are thinking about a lot, and you saw with Operation Warp Speed for COVID-19. Well, guess what? Before COVID-19 came along, people were thinking about vaccines for treatment of Parkinson's disease. Surprise. Vaccines are the tugboats of preventative health, as William Foch says, and he's been quoted many times now through this COVID-19 crisis. And the big question comes up. So we know the immune system plays a role in Parkinson's disease. We know inflammation plays a role in Parkinson's disease. And we know that we can give vaccines and we can kind of teach them to go at things that might be bad in the brain. And so a bunch of companies are working on this idea of, could you go to the brain and clear it off? So when you brush your teeth, you brush the plaque, okay, the deposits on your teeth off every night. What if you could take a vaccine and the vaccine would help you to scrub off the plaques, these alpha-synuclein, so-called Lewy bodies that are in different areas of your brain? Will that help Parkinson? Will it just give you a clean brain? Or will, like in Alzheimer's, when a similar approach was tried, will it lead to too many side effects? We don't know the answers, but we do know there have been several safety studies now, several companies in the space, and there's even companies that are directly injecting what are called monoclonal antibodies, something you've seen in the news also with COVID-19. Again, you put the antibodies directly in, and hopefully they go and knock down something that you think is bad. So good cop, bad cop kind of a deal. And so there are lots of neuroimmune approaches, and this gets at this idea of the neuroimmune system, neuroinflammation, and are we going to see combinations of therapies taking advantage of this when we think about what's emerging? And this is a slide from a recent article that we wrote with Boss Bloom and Christine Klein, just talking about all these approaches. And what I want to do with this is, I hate showing slides to people that are so busy that you can't read, but sometimes I do it just for fun. And the reason that I'm doing it just for fun to you isn't to torture you. My eyes are bad, I can barely see it, and I'm looking at the screen directly. It's to tell you that on this chart, people are looking at a molecule called synuclein. They're looking at misfolded alpha-synuclein fibrils. They're looking at a pathway in the brain, the garbage compactor pathway called the autophagy lysosomal pathway. They're looking at how calcium ions kind of keep cells and things together and in their what are called homeostatic, or the normal versus the abnormal states. They're looking at the powerhouse areas of the cell, the mitochondria, particularly in Parkin. They're looking at neurotrophic factors. They're like Miracle-Gro for the brain and how those could be developed into emerging therapies. We talked about inflammation. They're looking at inflammation from multiple different angles, including, as we talked about, the neuroimmune system. And they're looking at oxidative stress, particularly in one of the genetic forms of Parkinson called DJ1. And vaccines and neuroinflammatory therapies and diets and the microbiome and cannabinoids and novel druggable targets and gene therapies and next generation deep brain stimulation therapies, those are already kind of in testing. But what I want to make sure that I'm conveying to this group is there are a lot of approaches, and we're trying to guide those approaches by what we found in the laboratory. Sometimes we get lucky, but obviously better to have thought through this, understand the pathways, and design something reasonable for folks. And so there's a lot of action that's going on, and sometimes you don't see all that action. And one of the reasons we need to increase the funding by 10 times is look at this slide. We got to get more and more of these approaches going on every different area so we can see where they overlap, we can see what's working, and we can get to better therapies. So $200 million a year isn't going to do it. We need to get to $2 billion or $3 billion a year like HIV therapy so we can fill this slide up. And finally, it's not going to matter as much unless we develop biomarkers. And the reason for that is the following. People talk about biomarkers where you take a test and you tell you have Parkinson or not. But most of you who are listening now, we kind of know if you have Parkinson or not. And most of the time, we don't need an expensive test. Occasionally we do, but it's not as pressing of a need when we're talking about an emerging therapy. So what do we need for an emerging therapy? We need a test that's going to allow us over time to measure the progression, not a test where we're tapping our finger and we're saying, is this a 0? Is this a 1? Is this a 2? That's inexact. We want to see a test where we see how the brain changes or how some marker changes, called a biological in the body, a marker that changes over time. And if we can track that, then we can tell, are these therapies actually doing something to the relevant brain structures and to the networks in the brain that are lighting up, and how are they changing over time? And so there's a very large study that Angela Barampos, David Valancourt, and I are doing in partnership with the Parkinson Study Group through a National Institutes of Health grant, where we're beginning to look at one of these biomarkers called free water imaging and beginning to look at how we can register, and then later on how we'll be able to look at progression. There are lots of these approaches. Could be blood, could be saliva, could be skin. I mean, there's lots of things, but learning how to track progression, I think, is going to be super important as we develop the emerging therapies. So I'm going to come back to this slide, which is my favorite. I always say the person with Parkinson is the sun. They're in the center. Everyone should orbit around them. When we think about research and emerging therapies, this means that too. It's not just care. It's not just education. It's also research. It should all revolve around the person with Parkinson. We should be thinking in a much more multidisciplinary fashion. So thank you for allowing me to speak. I'm super excited about the Cole Center. I've met the folks that run it and what they're constructing and what they continue to grow there in Tennessee is just going to help so many people. And we need to help each other. And so it's great to have friends in Tennessee. We're in Florida. And we're happy to help any way that we can. And certainly we have folks who come back and forth for vacations and have homes in your area as well. And so feel free to hit us on our Twitter account if you want to become part of some of those secrets, videos, and cool things I do with my daughter each week. If you want to get on our blog, we have experts, answer questions and answers each week, which is I think really cool. And then some of our books where we send the money toward charity. The Ending with Parkinson Disease is about the direction that we need to take. The Living with Parkinson and Parkinson's Treatment. Those books in our series are much more about tips if you're looking for tips. And so with that, I will say thank you so much. It's been nothing but an honor to be part of your great event. And I wish everybody a great symposium, and I will be available to answer questions. And then also you can reach out to me on any of the handles. So hoping you have a great day. Take care.